let's get started. So, welcome everyone. Before we get started, just a reminder this session is being recorded and will be shared afterward. To help ensure the best audio experience for everyone, please keep your microphones on mute. Thanks for your cooperation. So, today we're going to be looking into running kinematics. We have two great, fantastic guests with us today, Krista Willie and Jeff Taylor Haas. Do you guys want to introduce yourselves quick?
Yeah, I'm Jeff Taylor Haas. I'm a sports physical therapist at Cincinnati Children's Hospital. I've been working here for about 17, 18 years now. I've been a physical therapist for over 20 years. And my population that I treat are injured adolescent long distance runners. I'm excited to be here today.
And I'm Krista Willie. I am also a sports physical therapist, my population of interest is primarily endurance athletes. I work with endurance runners, a lot of high school runners in our local community hospital, and I also teach biomechanics and human movement in the engineering department at the University of Wisconsin-Madison. So excited to share some running content with you today.
Great. So, first, we're going to have Jeff start with the key phases of the running gait cycle, and then Krista will review how to apply these running specific spatial temporal measures to running athletes, and then go into how kinematics impact muscle activation, joint load, and injury potential for athletes. Finally, Jeff will review the impact these variables are that certain variables such as sex, maturation, age, strike pattern all have on rehabilitation for runners. And then at the very end, we will have a Q&A and discussion, but feel free to plug questions into the chat as well. I believe our presenters are gonna try to respond to some of those as well during the presentation. And like I said, hopefully at the end, we'll have time to wrap that up. So with that, I think the floor is Jeff's.
All right, I'm going to try to make this share work correctly. It's funny how I just worked on it, so looks like. All right.
Looks
so
great.
do you just see my title slide? All right, we good to go?
Yep.
Okay, great. All right, so we'll get this started here. So Matt just went over our objectives, so I'm not going to restate them, but I want to make sure that we're going to hit these 4 objectives tonight. I'm going to tackle objectives 1 and 4, and then Krista will tackle objectives 2 and 3. So our first objective is just to identify the key phases of the running gait cycle. And of course, I think it's important to take a brief step back and just briefly talk about the difference between walking and running. And I think we can appreciate it's like talking about apples and oranges. During walking, when the foot hits the ground, our center of mass is rather low, and then it elevates at mid-stance, and then by toe off, it is lowered down again as we move towards our next stride. In running, when we land, our center of mass is the opposite. It's quite high, and it lowers down to its lowest point at mid-stance. And then at toe off, our center of mass is elevated again as we enter the swing phase. And our center of mass will reach its peak position during mid-swing. So what's happening during running is the transfer of energy as we transfer from gravitational potential energy to kinetic energy. So when we hit the ground and our center of mass is rather high, we have potential energy that can be used. So it's like the car at the top of a roller coaster. And as that mass is further from the ground, the potential energy would be higher. What's happening next is as we go from initial contact where our center of mass is high to mid-stance, as our center of mass is lowering down, we're transferring potential energy to kinetic energy, or the energy of motion. And as, just like a roller coaster car, as it's racing to the bottom of the track, kinetic energy at this point is highest and potential energy is lowest. And so in running, to make running an efficient process, we need to efficiently transfer energy. And the way that we do that is generally through our muscle tendinous units. From initial contact to mid-stance, we are depressing the springs of our lower extremity, particularly at the Achilles tendon, the patellar tendon, and the quad tendon. And that energy that we are depressing into our tendons will then be released in the second half of stance as our center of mass rises. And essentially this efficient transfer of potential and kinetic energy through our musculotendinous structures enables us to run efficiently for long distances. If it was just up to muscles to generate enough force and we didn't have tendons, we wouldn't be able to run efficiently, and we wouldn't be able to run for very long, if at all. So let's look at the different phases of gait. So let's start first by looking at the stance phase. And this is the portion of the stride when the leg is in contact with the ground. And it represents approximately the first 40% of the running gait cycle. And this is from initial contact to toe off of the same limb. Mid-stance during this stance phase is the instant in time that divides stance phase in half. And at this part of the gait cycle, this is when our body is at its lowest point, or when the center of mass is at its lowest. And this is approximately 20% of the total stride cycle. And then toe off is that instance in time when the foot is no longer in contact with the ground. And this occurs at the end of our stance phase, which is roughly 35 to 40% of the stride cycle. The remainder of time is swing, and that's the portion when both legs are off the ground. And that, of course, is one of the key differentiators between walking and running, is that in running we have a double float phase, and in walking we do not. I wanted to show this kinematic plot because this is something we'll review here when we look at the ankle, the knee, hip, pelvis, and trunk. So this is a typical kinematic plot. And on the x-axis, this represents the percent of the gait cycle from 0 at initial contact to 100 when that same foot is about to hit the ground again. The y-axis represents joint motion. And on this y-axis, 0 degrees will represent full knee extension because we're looking at the sagittal plane knee position. Any value above 0 is knee flexion, so increasing amounts of knee flexion. Any value below 0 would be knee hyperextension. On this plot, when you're looking at a red line, that is the right side of the body, and on this plot, the blue dashed line is the left side. And what we can really appreciate if we're looking at the knee at mid-stance, that's when the runner is at peak knee flexion during the stance phase. But we can really appreciate that the peak knee flexion and swing is well more than double what we see in stance. So this is a kinematic plot that we look at. You may see this in papers, and this is a nice representation of the movement pattern at the knee in the sagittal plane. Before we get into specifics, we want to go over a few key terms. So first, let's just define kinematics. So this is the description of motion without reference to the forces that cause that motion. So we're talking about joint angles, joint position, and the orientation of body segments. Whereas kinetics describe the forces that cause motion. So, most commonly we look at this as ground reaction forces. It's a little bit beyond the scope of this lecture to really get into kinetics, although we might share a few slides on kinetics. A talk focused on kinetics would be a topic for a future webinar. Here we're going to take a look at the foot and ankle in the sagittal plane and the coronal plane. So this is, again, looking at the kinematic plots where in the sagittal plane on the left, the neutral line would be the foot that's in a plantar grade position. Anything above the line is dorsiflexion, anything below the line is plantar flexion. And then in the coronal plane, we're looking at foot progression angle, which in essence is the amount of toe in or toe out. Here, anything below the 0 is relative toe out, anything above the 0 is relative toe in gait. When we look at the sagittal plane at the foot and ankle, what we can really appreciate is the vast majority of our runners at initial contact are rear foot strikers, relative, somewhere in the neighborhood of 75 to 90% of all runners are rear foot strike runners. The center of mass is high at initial contact, and then at toe off, that foot is now in a plantar flex position as we're lifting off towards the flight phase. On the right, you can see the picture of the coronal plane and different foot progression angles. This is a nice picture courtesy of Susan colleagues from 2016. And we can appreciate toe out gait on the left, a more neutral toe position in the center, and a toe in gait position on the right in that C position. And these are all variations of normal, although it is much more common to have a toe out gait than it is a toe in gait when it comes to running kinematics. Speaking of how the foot strikes the ground, one concept is that you should be aware of its strike index. which is simply the center of pressure at foot strike divided by the runner's foot length. And I think this next picture does a good job of explaining it. So if you're a rear foot strike runner, that generally means your foot strike index is between 0% to 33%. If you strike the ground first with your forefoot around the 67% to 100% mark, you're considered a forefoot strike runner. And then midfoot is in the middle, 33% to 67% of that strike index. And this is generally considered like the foot flat strike pattern. And again, a lot of runners rear foot strike. When we talk about how we treat running injuries and the risk of different running injuries in future webinars or journal clubs, we can talk about the relative pros and cons of each strike pattern. Another term to be aware of is foot inclination angle. So on the left, again, courtesy of Susan colleagues, is a runner with two different amounts of foot inclination angles. So this is the angle the shoe makes with respect to the horizontal. On the right, we're looking at tibial inclination angle, and this is the angle the tibia makes with respect to the vertical at initial contact. And researchers and clinicians often measure these angles kinematically to infer kinetic forces acting upon the lower leg during running. And so there are some pretty nice papers, and I know Krista has written one of them, where you can measure certain values in the sagittal plane kinematically and have some level of inference into the kinetic forces acting upon the lower extremity. And so when we talk about kinematics, it's important to keep these values in mind. Foot inclination angle being different than ankle dorsiflexion, which is the measure of the foot with respect to the tib fib. Finally, this is switching gears now at the foot and ankle. We're looking at rear foot eversion here. And rear foot eversion is the calcaneus position with respect to the tib fib. So most runners land slightly inverted, and then around peak position of mid stance is when most runners hit peak rear foot eversion, and then the foot will resupinate and move towards an inverted position again at toe off. And when we get to gait analysis, we can discuss more the relationship between this value and the risk of sustaining certain running related injuries. Speaking of, there's a nice paper by Kuhlman and colleagues in 2016 looking at a collegiate cross-country population who found that runners who went on to get any injury had higher amounts of peak rear foot eversion versus healthy runners. So there is some low-level evidence linking this value to injury, and in future discussions, future webinars, we'll get into that deeper. Moving on to the knee and the sagittal plane, we're looking at sagittal plane kinematics. So this again is a plot we saw previously. Again, at initial contact, runners land with their knee relatively extended. At mid-stance, you hit peak knee flexion for the stance phase, and then the knee starts to extend again as you get towards toe off, and then rapidly flex throughout the swing phase, where it hits peak knee flexion at mid-swing, and then as the runner is reaching the leg forward towards initial contact, again, the knee will extend. On your right, looking at the coronal plane, we can look at knee varus versus knee valgus, and we'll show you a couple pictures of that to drive home that those kinematics. Here's the knee in the sagittal plane. Most runners land with their knee relatively extended at initial contact, and then, as we said, you hit peak knee flexion around mid-stance. And these are values that we often look at when we're doing a 2D gait analysis. Here's pictures of two different runners running with relative amounts of knee abduction. And knee abduction is defined by the distal tibia moving laterally with respect to the femur. And when we get on later on in this evening's lecture, we'll talk about how we see kinematic differences between men and women. Here's a picture of a runner in knee adduction, which we often call varus clinically. And this is when the distal tibia is moving medially with respect to the femur. It's more common to see variation in kinematics in the knee and the frontal plane than in the sagittal plane. Excuse me. All right, moving on to the hip. In the sagittal plane, we're going to go over hip flexion and extension, and in the coronal plane, hip adduction and abduction. When runners hit the ground, they're actually at peak hip flexion in the stance phase. And on the flip end, right when you're just past toe off into initial swing, that's when peak hip extension occurs just after toe off. And these variables are impacted by how fast the runner is running, as well as factors such as their leg length. And so when runners are running with higher cadence values, as cadence goes up, their stride length tends to go down, which can impact how much peak hip flexion and hip extension the runner experiences during the running gait cycle. Here, as we look at hip adduction, this is the femur moving medially under the pelvis. It's important to bring in mind this concept of coupled motion, and that is when joints move synchronously with each other due to their anatomical articulations. So as the hip adducts, it also internally rotates, and the knee internally rotates as well. And finally, as those motions are occurring, the knee is often, it will abduct. So when we're looking at peak hip adduction, it's generally coupled with knee abduction. And just like knee abduction, the peak for hip adduction typically occurs at or near mid stance. And we'll be looking at this value further when we look at sex differences between males and females. In the pelvis, in the sagittal plane, it's really important to note that all runners run with an anteriorly tilted pelvis. I think I've seen just a handful of runners come to the clinic with the pelvis in either a neutral position or slightly posteriorly tilted. That is not normal. It's much more common to run with your pelvis tilted anteriorly throughout the entire stance and swing phase. And of course, pelvic obliquity is something that a lot of runners look at, or a lot of clinicians look at during a 2D gait analysis. So here's an example of anterior pelvic tilt. So peak anterior pelvic tilt occurs right around the time of initial swing. So as we can appreciate, hip extension is coupled with anterior pelvic tilt, as well as lumbar lordosis in the spine. When we're looking at pelvic obliquity, contralateral pelvic drop, which refers to the pelvic position with respect to the horizontal, that occurs right around mid-stance. And clinicians often measure this during a gait analysis to infer injury risk and muscle activation. And it's something that we absolutely will be talking about in future lectures. But it's important just to make sure we have a framework of reference when we're talking about what do these values mean and when do they occur. Finally, we're going to look at the trunk, again, sagittal and coronal plane. Trunk position tends to vary a little bit more than in the sagittal plane than it does in the coronal plane. You'll see some runners run with a very erect trunk posture. Some runners almost will lean backwards a little bit when they run, and others will lean forward more. And there is some debate about what is the best trunk posture in the sagittal plane. So here, looking at anterior trunk tilt on this runner who happens to be my daughter, so she gave me permission to share her video. She's running with a more traditional anterior trunk lean, which we typically see as a more normal trunk position with a little bit more trunk lean in the neighborhood of 7 to 10 degrees. And from the lateral or the posterior view, we can see a lateral trunk lean. And this is looking at the trunk position with respect to the vertical. And again, we can use this clinically during a gait analysis to infer injury risk, muscle activation, and also sometimes habit for runners who are returning from an injury. So in summary for this first section, kinematics, which is the heart of our talk today, is description of motion without referencing the forces that cause motion. And these kinematics are often best appreciated during a video gait analysis, which is a topic of a future webinar. So I'm going to pause there, and I'm going to stop sharing my screen so that Krista can take over.
During that transition, feel free to type any questions you have in the chat, and Jeff will be able to try to get to some of those while Krista's talking here.
Thanks, Matt. Thanks, Jeff, for kicking us off here. My goal is to dive in and start to expand on the definitions and the key terms that Jeff introduced. And I will next move into understanding and applying spatial temporal parameters as we discuss them in the running athlete. So to define a spatial temporal measure, these are the metrics that we look at in runners that capture both some essence of a spatial or a position and a distance and a temporal, so some component of time, speed, or duration while our patients are running. The key spatial temporal measures that I'll introduce and expand on include stride length, step width. We'll talk about center of mass vertical excursion, and then finally step rate as well. So first, we'll take a look at stride length. Stride length is defined as the distance from one heel contact to the sequential contact of the next foot. We'll also talk about step width here, and that's the medial lateral distance between the heels of each feet. And then finally, step length is the anterior posterior distance from one heel to the next immediate step. So that's the distance between the right and left foot. So different feet there in that case. And on the right side of your screen, you see how we typically clinically apply this. Oftentimes there's different definitions and applications of these measures when you look at them in the research, in the literature, when clinicians and scientists in those cases have every tool and toy at their fingertips. That, in this case, that would be a force plate or a force instrumented treadmill. But oftentimes clinically, when we have a two-dimensional video that we're looking at and analyzing, we have to modify those variables, those parameters slightly to work with and fit within the bounds of what we have. And in this case, that would oftentimes we describe that as the heel to center of mass distance, and that's indicating a component of that stride length within one limb only. If we take a look more closely at step width, again, that's the medial lateral distance between steps. And oftentimes we hear this called base of gait as well. And in order to understand what's happening between limbs individually, oftentimes clinicians will look at the distance, not necessarily between feet, between the right and left foot, but between the foot in contact with the ground and a line representing the position of the center of mass. And that's what we see in the image on the right with the gentleman on the treadmill. And then I would, in that video, I would take that distance, what I would consider here a base of gait of that left limb, and I would compare that to the base of gait or the distance in this individual on the right limb as well. Another important measure is center of mass vertical excursion, and we define that as the vertical displacement of the center of mass between the lowest point in that gait cycle, which is the mid stance, and the highest point of the center of mass in that gait cycle, which would be the double flight phase. And again, oftentimes I use my surroundings here. There are sometimes anchors in the clinical application of this measure, and some anchors I pull are the waistband, the runner's waistband of their shorts, assuming that their shirt is tucked in and it's a tight-fitting short that an individual is using. You might also be able to use a reference behind the runner as well. In one of our clinics, we've got a whiteboard with a nice even ledge that might be behind that athlete, and that can be used when you freeze frame. Again, both right and left sides at those different respective positions, and you can compare the distances, the differences between those two positions. And then finally, the last spatial temporal measure I'll touch on is step rate. Again, this is commonly called cadence, in which those words are used interchangeably. How I clinically define this or identify this clinically is count the number of steps an individual takes by 1 foot in a 30-second period, and then multiply that by 4 so that you have the total number of steps that that runner takes from both feet within 1 minute. And that's how we define number of steps per minute. Again, when we apply that step rate measure clinically, oftentimes that's a variable that we use clinically because it is strongly associated with other kinematic variables and values, and I'll expand on that in just a second here too. But another reason why this has become such an important topic or such a widely used variable in running analyses is because oftentimes it's a very practical measure for runners to understand. Most runners, I should say. Oftentimes you can talk about steps per minute, you can play an audible sound of the number of steps per minute, and runners can easily identify with that and relate to that as well. And when we relate that step rate value to kinematic parameters, what we see is when there is an increased step rate or a higher step rate, that is correlated with a decreased step length, meaning that person, that runner, is landing with their foot more underneath their center of mass at initial contact. And what that does when they pull their foot more underneath them at that point of initial contact, that increases their knee flexion at initial contact. It decreases foot inclination angle, and it also decreases that measure we talked about, the heel to center of mass distance. So again, oftentimes, just in summary, that step rate modification or step rate variable is a convenient, a practical measure for us as clinicians to use to help elicit some of these changes or some of these desired kinematic outcomes in our runners. So with that basic understanding of some of those additional spatial temporal measures, we'll take things one step further here and now relate how some of those kinematic variables that Jeff introduced, the spatial temporal measures I expanded on, and we'll look at some applications of those values and variables to muscle activation, joint loads, and injury potential in our runners. I'll start first by touching on key kinematic parameters and the association between muscle activation and the common muscle groups in our runners. And if we take a hip down approach, I'll first start with the kinematic associations between the glutes and when and where we see those most active during the gait cycle. So just to orient us all to the images on the screen, again, we see that orange profile of the runner across the entire gait cycle. And here you can see I have focused our attention on the initial contact and the up to mid stance or through that mid stance of the running gait cycle. And then the image in your lower left corner is showing average EMG profiles of the glute specifically. So that top trace is showing average or normalized muscle activity of glute medius, and then the glute max are represented just below that. And here in this figure, what I want to draw your attention to is those muscle groups are most active during that first 20% of that gait cycle, the initial contact through that mid stance portion, through that loading response or energy absorption portion of the gait cycle. And that corresponds to the hip extension pattern that is happening, or that early hip extension that occurs from 0% to 20% of the gait cycle. So that active glute and the hip extension paired together are indicating there's a concentric activation of the glutes in that early phase of the running cycle. If we take a closer look at the quadricep muscles, again, we see those muscles most active during that 0 to 20% of the gait cycle here. And in that case, the quads are active here as the knee is flexing. So we're seeing an eccentric quad activation as the quads are helping to absorb that energy at initial contact and into and through that mid stance portion. Moving a little lower down the limb, the gastrocnemius muscle is certainly an important muscle for our runners as well. And here again, we see that muscle most active during the earlier phase, during that stance phase of gait, but now we're towards the middle. The glutes are a little more active towards the middle of that stance phase of gait, more closely active or linked to the mid stance and the push-off phase of gait here. And then finally, the last muscle group I'll touch on are the hamstrings, and both you see muscle activation profiles for both lateral hamstring and medial hamstring. And because these are biarticular muscles, that increased activity now towards the end of that gait cycle, towards terminal swing, is associated both with what's happening at that knee. The knee is extending in that position in that last 20% of the gait cycle. But because of the biarticular nature of the hamstring, it's also responsible for changes that are happening in the hip. And here now in that last portion, we're seeing initially some knee extension and hip extension that actually then moves pretty quickly into hip flexion and knee flexion as well to prepare the limb just before the moment of initial contact of the subsequent step again. If we take a closer look at how our kinematic measures are related to joint loads, and I'll expand this just a touch to look at loading patterns in general during running, I will expand on the study that Jeff did mention that we did several years ago, where we took our kinematic predictors, some of these common kinematic variables that we've been talking about in this first half hour, and we looked for associations or the strongest associations with those kinematic predictors to running kinetic measures, common kinetic measures. And as Jeff mentioned, we're not going to focus on kinetic measures here. In future talks, we will dive deeper into kinetics. There's a talk and a half in and of itself, or a talk or two in and of itself in running kinetics. But the motivation behind this study is that oftentimes in our clinical applications, we don't, like I mentioned, we don't have those fancy toys and tools and instrumented force plates at our fingertips, but we do have cameras and we can capture kinematic variables. And can we use those kinematic variables to tell us something about what the kinetics of that runner in front of us are? And we, in fact, did find some interesting relationships and associations. And the 4 kinetic or loading measures that we looked at here were peak vertical ground reaction force. And we haven't talked about this too much yet, but I'll briefly introduce these variables. Braking impulse, we looked at knee-specific, energy absorbed, and peak patellofemoral force as well. So for those that haven't seen this ground reaction force profile before, here is the common profile of a vertical ground reaction force in a runner. And again, that's the equal and opposite force that is acting on the individual here. So vertical would look at that force in the up and down superior inferior direction only. And then it's also important to take a look at the anterior posterior ground reaction force. Commonly in this position with the foot out in front at initial contact, that posteriorly directed force is associated with a braking impulse. That would just be the area under the curve of that posteriorly directed force that occurs during stance. And then during the first half of stance, you're only looking at the stance in these figures now. And then the propulsive impulse is the latter half of stance, as that anteriorly directed force is propelling the runner forward. So take home of this study was that some of those key spatial, temporal, and kinematic measures do in fact demonstrate an association with our kinetic measures. So step rate, center of mass, vertical excursion, and foot inclination angle did appropriately describe about 50% of the peak vertical ground reaction force values in the runners we looked at in this study. When we looked at braking impulse, again, we see a lot of those similar variables: step rate, center of mass, vertical excursion, and then we see 2 key kinematic variables at initial contact: the foot inclination angle, as well as the heel to center of mass distance at initial contact. And again, clinically, in my mind, that is linked because as that limb is reaching further out in front of you, those extended, that overstriding pattern at initial contact will have a direct association between the braking impulse that runner has to overcome in that early period of stance. Next, we'll take a little closer look at the knee loads specifically. So when you're looking at energy absorbed here, how much the knee joint specifically has to overcome or tolerate the load that knee joint has to tolerate, we see an association between step rate, foot inclination angle, and now we see peak knee flexion angle at mid stance playing a significant role here. And that's describing upwards of 60% of the variance in the energy absorbed of the knee. And then finally, we see the peak patellofemoral force is also strongly associated with both step rate and again, peak knee flexion angle. So taking a closer look at that, what's happening at the knee, we do see that an increase. In this case, we did cause an intervention. We did increase and decrease step rate in these runners, and we saw that increase in step rate led to a decrease actually in that knee flexion angle at mid-stance. That higher turnover, the tighter pattern, and therefore actually a decrease in step length led to both, or excuse me, a decrease in the knee flexion angle led to a decreased patellofemoral joint load, as well as a decreased energy absorbed in that knee. So a quick summary or take home of that overview is that these kinematic measures that we have been talking about, a lot of the spatial temporal measures we've been talking about, can be used to indirectly estimate some joint kinetics and loading during running. And in fact, we saw a lot about the limb posture and the kinematics at initial contact, and a couple at mid-stance may in fact influence loading patterns that are occurring throughout stance. And clinically, this is relevant to me because as I'm doing running analysis, I often focus primarily on what's happening at initial contact and what's happening at mid-stance, honestly, because that's the extent of what we can cover and break down in a clinical visit with some of these runners. But these studies, these results indicate that those limb postures at those key moments can in fact be telling of what's happening throughout that entire stance. And then finally, I'll touch on the injury associations or injury potential between these kinematic parameters and what we know about running injuries in our the populations we work with. And I want to add a warning here or a word of caution that just like anything, this relationship is complicated and it depends, but we can't give a clinical talk to a group of physical therapists without touching on injuries. So we're going to scratch the surface on what we know about the kinematic impacts on running injuries here. But the biggest word of caution I have is that the evidence we have in this field up to this point is honestly limited and inconsistent. And part of the challenge is because if we want to understand a true association of kinematic impacts on running and injury, we should look for prospective studies. We should start with a group of healthy athletes and monitor how the kinematics in a healthy population change or affect injury over time. And the body of evidence we have there is limited, although we'll touch on a couple that we do have. And Jeff will expand on what we do have too when we look at some specific populations, but we will also expand on that significantly in the follow-up webinar to this series. Next month, we'll start to focus primarily on clinical applications and pull in some key injuries that we commonly see with our runners and associated kinematic patterns. And then finally, the last point I'll make here is that, again, just like any patient, any injury we see that walks in our doors, it's multifactorial. And I think that is really important to remember in our runners. Today, we're talking about this one bubble, this one component of the puzzle, the running biomechanics. But training errors, musculoskeletal faults all play a key role into the injuries that we see for the patients in front of us. So a couple ties, a couple pieces of information that we do know are related between the kinematic impacts of running and running injury. We do see some changes or associations with loading patterns in our runners who do go on to sustain an injury. One study found higher braking impulse. Again, this was primarily in females. So you'll start to see here the importance of sex that Jeff will expand on in just a bit here. One prospective study that we did at the University of Wisconsin with our collegiate runners, we found that the runners who did go on to sustain an injury demonstrated at a healthy baseline a higher vertical ground reaction force and a larger center of mass vertical excursion. So again, indicative of the influence of those key spatial temporal measures. And then finally, there's also been some work that's looked at greater peak vertical ground reaction forces, but what might be even more important is the cumulative loading in injured runners. Lace Ludke, a colleague of ours, has done some work to look specifically at step rate and running injury. And in a high school population, she found that runners who had a low step rate in the lowest tertile group, less than 166 steps per minute, they were more likely to experience a shin injury than the runners who had a step rate above 178. She also looked at knee injuries, but did not find a significant association between step rate and knee injuries. So again, indicating that a lot of these findings may in fact be injury or population specific. And then finally, there is a little bit of evidence that's growing to support that peak hip adduction females, here again, we see in females, may be more strongly associated between patellofemoral pain and IT band syndrome. But again, we've got limited evidence there to support that. And to wrap up this section, we do know that there are kinematic impacts on injury, but we have limited evidence, limited strong evidence to support some of those findings. If we are to take a closer look at kinematic variables, we might want to keep a close eye on center of mass vertical excursion, step rate, and hip adduction angle. But finally, please keep it in mind that running injuries are multifactorial, and our running biomechanics really are only a piece of that puzzle. So now I'll turn it back to Jeff to expand a little bit more on some of these key measures in our niche populations.
Thank you. That was great. I'm going to get my slide to the right position. I was reviewing my slides, and as you were finishing up, I'm like, oh gosh, I gotta get to the right spot. So give me 1 second. Feel free to stand up and get some water. I don't know what happened to my voice in the beginning section there. My voice almost died, but it's back. So, all right, I think I can do it. So let me share my screen. That's not what you want to look at. Hold on a second. I think I can make the thing work. Let's see, slideshow from current slide. Yay, I can make it work. All right. Half the battle of a webinar is the technology. Probably more than half, since you all aren't here. But okay, so we're going to look at variables such as sex, maturation, age, strike pattern, and running speed, and how these variables impact kinematics, injury potential, and rehabilitation. So if the beginning part of this talk was sort of getting into the basics of running, I like to think this is getting a little bit more into the weeds. This is a little bit more into how, we all differ. So if you think of the beginning part of the lecture as like, kindergarten and we're all the same and we all move similarly, this is about how, no, that's actually not true. And I think if you practice clinically, you can appreciate this, but we'll get into what the literature has to say about this. So let's start by talking about, do running mechanics differ between sexes? And well, what we can say is it depends what you're looking at. So in the sagittal plane, the take home is that there are very few differences exist between sexes. For the most part, males and females have similar kinematics at the ankle, knee, and hip in the sagittal plane. And this also includes the timing of peak joint angles. So, you got Ryan Hall and his wife Sarah here. And in the sagittal plane, for the most part, we're going to see very similar movement patterns at the ankle, the knee, and the hip. Now, even when we move to the coronal plane or the frontal plane, we do see similarities. And that is more so with respect to the timing of coupled motion. So when I began my first part of the talk, I talked about how coupled motion is when you have motion that happens at one joint that concurrently is also happening in another joint, and that is those two move synchronously together, and that is generally related to the anatomical articulation of joints. So here we're looking at the relationship between peak hip adduction on the x-axis and peak knee abduction on the y-axis, and what we can appreciate is a rather linear relationship. As peak hip adduction increases, so do So too does peak knee abduction. This is a similar correlation between men and women. When we look at the rear foot in the frontal plane and the knee in the frontal plane, so here the peak rear foot eversion is on the x-axis and peak knee abduction is on the y-axis. Again, we see a similar relationship between males and females. This time it's a negative relationship. So as rear foot eversion is increasing, knee abduction angle decreases. And this will be something to keep in mind when we look at some sex differences here in a minute, particularly at the rear foot for men, because men at the rear foot run with higher amounts of rear foot eversion than women. So keeping this graph in mind will be helpful when we start to appreciate one reason why that could be. Now, structurally, men and women are built differently. Women typically have larger hip width to femoral length ratios, and this leads to a greater relative hip adduction, static genu-valgus, and greater static Q angle compared to men. It's important to note that while we know structural differences exist, it would be too simplistic to say all gait differences between men and women are attributed to structural differences. And one reason we believe this to be true is a study that I'll talk about a little later that I led, looking at the impact of maturation on kinematics between boys and girls who are in different stages of puberty. So, but we do need to, acknowledge structural differences exist, and they likely do play a role in some of the kinematic differences we're going to talk about next. And the largest being what happens at the knee and the hip, primarily in the frontal plane. Kinematically, that's where we see our largest differences. Looking at initial contact, peak joint position, and stance phase joint excursion at the hip and the coronal plane, women have greater hip adduction angles compared to men at each one of these values. Additionally, in the transverse plane, women exhibit greater hip internal rotation peak joint angle than men. And this has been, demonstrated in many different study populations of adult runners, both healthy and injured runners. At the knee, women run with greater knee abduction angle at initial contact and mid-stance than men. And in the transverse plane, women run with the knee more externally rotated than men as well. And this plot shows you the relative difference between male kinematics at the knee, which are in black, and female kinematics in gray when looking at the frontal plane knee angle during the stance phase. In general, if you're looking at a population level, adult female runners run with their knees in a relative more abducted position than males. Now, at the foot and ankle, particularly at the rear foot, we see that peak rear foot eversion is higher in males than in females. And this makes sense when we go back to the knee. Men tend to run with the knee in a more relative adducted position than women do. And in this more adducted or varus position, the proximal tibia is angulated more laterally with respect to the distal tibia. And this makes the position of the calcaneus in a relatively more everted position. And it's believed that this is one factor in why men experience more Achilles tendon injuries than women, particularly at the recreational adult running population. And it's likely that this kinematic difference between males and females partially explains the difference in injury rates. So a few key take-home points. When we're looking at females, they tend to run with increased frontal plane hip and knee stressors. It's more common to see a quote-unquote medial collapse gait in females, which we'll talk about next month when we get into our gait analysis webinar. Men, on the other hand, have increased Achilles tendon stressors than women do, and this is likely due to running with relatively more rear foot eversion, but that's not the only factor, it's just a factor. And finally, men and women have similar sagittal plane kinematics when we are comparing kinematics between sexes. All right, maturation. This is my population. Let's get excited for this. So there's been, little work in the literature looking at the impact of maturation on running kinematics. So I want to briefly review a paper that I authored in 2022 with a group of awesome colleagues and contributors. And in that cross-sectional study, maturational status was obtained using the pubertal maturation observation scale, also known as the PMOS. We placed participants into 3 maturational categories: prepubertal, which corresponds to the Tanner stage of 1, pubertal, corresponding to Tanner stages 2 and 3, and postpubertal, corresponding to the Tanner stages of 4 and 5. And here's a summary of our key findings. And I realize this table is busy, so I'll do my best to share with you our key findings. We focused our efforts on pelvic and hip kinematics for this paper. And interestingly, at the pelvis, at each stage of puberty, females demonstrate increased pelvic obliquity range of motion comparison to males, and also with respect to each other. So as females are going, prepubertal females run with less pelvic obliquity range of motion than pubertal females, who run with less pelvic obliquity range of motion compared to postpubertal females. When we look at other key variables, such as peak hip adduction angle, here there's a key sex difference. At each stage of puberty, which we found surprising, the females ran with more peak hip adduction angle compared to males, even at the prepubertal level, which, if you go back to the previous slide where we're talking about structural differences, this would suggest that even though we know structural differences tend to emerge at puberty and become more magnified in the postpubertal status, at the prepubertal status, we don't see as many structural differences at the hips between females and males. So it's interesting that we found this difference between males and females. We also found peak hip internal rotation angle was higher, which if adduction is higher, generally hip internal rotation angle is higher, so that's not too surprising. When we look at males, males at every stage of maturation had higher peak hip external rotation angle compared to females. And the last thing I'll point out on this slide is peak knee extension angle, which we'll talk about here in a minute. But interestingly, our postpubertal females land typically at initial contact with their knee more extended than both prepubertal females and pubertal females. And this is an interesting finding because it suggests that our postpubertal females are adopting a movement pattern that's different than the pubertal and prepubertal runners. We don't know why they're doing this, and you can speculate at the potential injury risk differences, but we thought that was something we wanted to share tonight. So looking at that pelvic obliquity angle in terms of range of motion, you can really see the stepwise progression. This is a violin plot, and we can see at each stage of maturation that range of motion is increasing from the prior stage of maturation. Looking at peak hip adduction angle, we can really appreciate at every stage of maturation there's a main effect of sex, such that the female peak angles are larger than the male angles at every stage of maturation. And as Krista was saying, this likely increases the risk to the knee. That's been borne out in some prospective work. And it might suggest there may be a sex difference in how you treat knee injuries in adolescents, females than males. We may be working more on frontal plane stability in our female population. And in males, it may very well be we're looking at something else, perhaps more sagittal plane stability. Going back to that peak knee extension, statistically, we did some pairwise comparisons, and in this sort of, I guess that's a yellowish color, that's our prepubertal runners. Here's our pubertal runners, and here's our postpubertal runners. 0 is getting you to knee extension more, this is 5 degrees of knee flexion, 10 degrees of knee flexion. And we can really see those pairwise comparisons where we see differences between our postpubertal runners who land with their knee more extended compared to our pubertal runners and our prepubertal runners. Males, we don't really have any relationship at all. And we almost had a sex difference between our postpubertal females and our postpubertal males. although it was not statistically significant. So what does this all mean? We have to have some caution. This is a cross-sectional study. It wasn't a prospective cohort study, although we have some pilot data we're looking at currently. But what this tells us is that prior to puberty, boys and girls demonstrate few kinematic differences, but they do exist. And that was surprising to us as authors. We thought that similar to the ACL literature, we would not see kinematic differences really emerge until puberty. Now, girls demonstrate significant maturational differences at the pelvis, hip, and knee during running that males do not demonstrate. And the pelvic, hip, and knee mechanics demonstrated by the pubertal and postpubertal girls may, in theory, increase the risk or their susceptibility to certain running-related injuries. But as Krista mentioned, the only way to really bear this out would be prospective cohort studies to determine risk factors that led a runner to getting injured. Switching gears, we're going to talk about a topic near and dear to my heart as a middle-aged runner, which is aging and running biomechanics. This is a great picture. This is Joan Benoit in 1984. She's winning the Olympic marathon in LA. This is Joan Benoit Samuelson, 2008, running in the U.S. Olympic trials. She had a very long career running and making U.S. Olympic trials. She didn't make the team, but for many years, all the way up into 2008, I think, she was able to qualify for the trials, which is fantastic. That's a period of 24 years. You don't see Usain Bolt or Carl Lewis out there trying to run down the young guys in their 40s or 50s. And why is that? Well, here's the depressing slide. As we age, we get fatter and shorter, and we get weaker. And where do we lose our muscle mass? We'll see this in a minute, but our quads and gastrocs. And we primarily lose our type 2 muscle fibers more so than our type 1s. And we know type 2 are used in sprinting and power activities. We do also have a reduction in maximal dynamic strength due to sarcopenia. And as we age, our bone mineral density tends to decrease as well. Now, oh yeah, I wanted to make sure I kept this slide. I made a note that I didn't change, so sorry about that. But this is a nice paper. This is a graphic by David and colleagues looking at what happens with age. And with respect to speed, the decrease in running speed that happens with age is primarily associated with the decrease in stride length, but not stride rate or stride frequency. And other things that are associated with the reduction in running speed are spending a little bit more time in contact, but also having reduced magnitude of that active ground reaction force that Chris was talking about. This is the force of push-off, and this is led primarily by your ankle plantar flexors. And with reduced magnitude of that active ground reaction force, we see a reduction in ankle power. Going back to looking at cross-sectional area, you can really appreciate that our quads really go south as we age, much more directly than our plantar flexors. This R-squared value of 0.52 tells us that 52% of the variance of the knee extensor mass reduction is directly attributed to age, whereas for the ankle plantar flexors, that variance is only explained by about that reduction in circumference is explained by 20%. So there are other factors that explain ankle plantar flexor mass reduction, but age is a significant variable. What else happens as we age? So we mentioned that stride length goes down. It's likely related to your ability to push off the ground. If you can't push off the ground very hard with your calves, you're not going to be able to take a long stride. To counteract that, older runners will typically increase their cadence or their stride rate. Because they're slowing down, they tend to spend more time in contact than younger runners. And we can really appreciate the reduction that's happened at the ankle in terms of ankle power, strength, and cross-sectional area. Also in the calf, we get tighter calf muscles as we age. We see reductions in hip strength and also reductions in hip external rotation range of motion. So things change as we age, and where this tends to play itself out is, in essence, as we age, the kinematic chain is stiffening. Stiffness is force, looking at forces with respect to changing range of motion that the limb goes through, particularly during the stance phase. And as we age, we tend to go through tighter ranges of motion, particularly the ankle and the knee. That makes our kinematic chain stiffer. This likely leads to increases in impact forces such as loading rate. And again, because we're not able to generate as much torque out of the calf muscle, our active ground reaction force decreases, which is the number one attributing factor to reduced stride length. So, that can hit you pretty hard if you're, 45 years old and still out there trying to run fast. Good news, you can still strength train and you can still do some work to try to slow down some of these variables, but time will catch up with all of us. And it's important to keep these variables in mind if you're clinically seeing a 55-year-old runner and then the next runner you see is 25. Those two runners should run differently. And just because the older runner is running with a higher cadence and may look to you like they're understriding clinically, just keep in mind they may be doing that because that's a natural sequelae of aging. Okay, running biomechanics and strike pattern. Again, we could probably spend an entire hour talking about strike pattern. I've been to lectures where the key presenters are going over this for quite a while, and sometimes they're telling you why one strike pattern is better than another. I've been practicing for over 20 years. I've seen the pendulums shift side to side, and in future lectures, we'll talk about the relative pros and cons of different strike patterns. But suffice it to say, I don't think there's one perfect strike pattern out there. But let's talk about what we know about the kinematic and muscle activation differences between the strike patterns. So in general, there's three basic ways you hit the ground. You hit the ground either with your heel first, rear foot, midfoot, or forefoot. And in a systematic review and meta-analysis done by Almeida and colleagues published in AASPT, they succinctly identify what are the key differences between a rear foot and forefoot strike. And we all know rear foot strike runners are going to land dorsiflexed and forefoot strike runners are going to land plantar flexed. But what's interesting are the other, the two kinematic variables here. When you land with rear foot strike, you tend to land with the knee a little bit more extended or less flexed. Conversely, a forefoot strike, the knee is a little bit more flexed. So, if you're working with an injured runner, perhaps who has like perfect cadence for their leg length and speed, and you're thinking, geez, I've done everything under the sun to get this person better, could you try to reduce knee stressors at initial contact by having a forefoot strike? You could, but as the next slide goes, you'll have to be prepared for the anticipated side effects of that change. At the rear foot, if you're forefoot striking, you're going to go through a larger rear foot eversion excursion. So in my clinical practice, I've seen runners adopt a forefoot strike pattern because they were told it's the best way to run, who were previously rear foot striking, and then they come in with Achilles calf pain. The calf pain makes sense because now they're landing on their toes, but they're often surprised that their Achilles hurt. And one reason their Achilles may hurt is the Achilles is a secondary control of pronation. And finally, vertical loading rate tends to be higher in a rear foot strike runner than a forefoot strike runner. But as Krista alluded to, it's likely cumulative loading is a larger issue in an endurance runner than vertical loading rate is in of itself. But that's a discussion for a future time. Here we're looking at muscle activation and strike pattern, and I want to just highlight some key differences here. So right before the foot hits the ground, we call that the pre-activation phase. So that's terminal swing. And we can appreciate in terminal swing, a rear foot strike runner is pointing their toes up, they turn on their anterior tib, and a forefoot strike runner is pointing their toes downward, they turn on their calf. In stance, you can really appreciate the difference in anterior tib activity versus gastroc activity. If you're rear foot striking, you're going to use more anterior tib than forefoot, and vice versa for the calf. So, if you're working with a runner with anterior exertional compartment syndrome, one of the only ways you can really treat them that I found to be successful over the years is strike pattern manipulation. I don't do it very often, but over the summer I was working with a collegiate runner who was about to have surgery on her anterior compartment, and I said, well, why don't we try strike pattern manipulation first? I shared with her, her calves are going to kill her, but her shins should stop hurting, and if we can adopt it slowly, she should be able to, successfully move on and hopefully avoid surgery. And over time, that bore itself out to be true. But when she came back to me and said, boy, my calves are killing me, I said, well, we increased your calf work roughly double than probably what it was used to doing. And this slide helps bear out why that's the case. It's also important to note that forefoot strike runners are going to use a little bit more hamstring activity and hip flexor activity. Not terribly different, but enough that it was statistically different. So just something else to point out. When we shift gears and we look at running speed, running speed is probably the number one reason why we don't have kinematic norms. So in the chat, someone asked the question, what is the normative value for, I think it was swing, knee flexion and swing. And I think one of the comments I made as well, that value, peak knee flexion and swing, is going to vary based on running speed. In fact, running speed is the reason why, if you're doing gait analysis on a runner at one day and then you see them 2 months later, you really need to keep speed consistent if you're going to look at the gait from day 1 to 2 months later. And that's because speed directly impacts our kinematics. And when we look at speed, there's really 2 ways to run faster. One is to have a longer stride length. So when you have a longer stride, you push on the ground more forcefully through your gastroc and your soleus. That'll propel you toward your next stride. And the second is generally to increase your stride rate. You're going to push harder on the ground more frequently. You're going to do this by reducing your stance time and your swing time. And this is going to increase stress to your hip flexors, your hamstrings, and your glute max. Because in essence, what we're looking at with speed, it is it's the amount of distance you can cover in the least amount of time. So you're either going to take a longer stride to cover more distance, or you're going to try to pick your foot up the ground faster to spend less time on the ground and reduce that time variable. This is a nice paper put out by Seish back in 2014. And on the x-axis, you're looking at runners at different running speeds, so 2 meters per second all the way up to 9 meters per second, which is basically an all-out sprint. And then you're looking at the stride length on the y-axis. And what we can really appreciate is as we go from slow running, which is very slow running, to moderate pace running, that's the change from 2 meters per second to 3.5 meters per second is primarily driven by a change in stride length. Now, as we go faster, you can really appreciate that stride length starts to decrease because we are maxing out the amount of stride length we can get out of our body. Flip it around, when you go from fast running to sprinting, the biggest change is by stride rate. And so we can really appreciate that when runners go from slow running to fast running, the first thing they do is they just lengthen their stride because it's the most efficient thing to do. But at a certain point, we run out of stride length, and then all of the changes in speed are generally going to be driven much more by stride rate than stride length. And so in the beginning, if a runner is starting to work on some speed work, and let's say they're going from like a nice, easy recovery run, and maybe they're running 10-minute miles, and then I'm going to go to the track and I want to do some tempo running. So now they're maybe running 7:30 to 8-minute pace. That change from that 10-minute mile pace to 8-minute mile pace is really driven by the calves. They're taking longer strides. So if they're like, my calves are sore, for me, when a runner says their calves are sore, I'm like, okay, have you been doing some speed work? Have you been doing any hill work? Now, once we get to about 6 to 7 miles meters per second, which is 13 to 15 miles an hour, force generation of the calf muscle plateaus. And if you think about it, you know, isokinetically on an isokinetic machine, if you're measuring torque, we get peak torque values at the slowest speeds, and that's because as our at the cellular level, as we're trying to generate torque, the slower the joint motion, the greater the torque you can generate. As joint motion increases, torque values generally decrease. And once you get past 13 to 15 miles an hour, the duration of stance phase is going to decrease, which means you reduce the ability to generate torque. It's just the movement's happening so fast that really now you must increase your stride rate. And that is going to increase muscular demands at the hip, particularly the hip flexor, the hamstring, the glute max. And so, you know, if a runner's coming to you and they have a hamstring injury, 9 out of 10 times it's because they started doing speed work, or you know, or they do activities where they're doing some level of sprinting. I don't know if I've ever treated a runner who only did slow distance running who had a hamstring injury. I've had runners think they had hamstring injuries and then they had, you know, like a disc injury. But generally, if it's a true hamstring injury, that's a speed-related phenomenon. So in summary for this section, when we look at adult male and females, they run with different kinematic patterns. Females, we see greater coronal plane hip adduction and knee abduction. Males, we see greater coronal or frontal plane knee abduction and rear foot eversion. Maturational differences do begin at pre-puberty, but they seem to accelerate during and after puberty. Strike pattern differences are most pronounced in the sagittal plane, and it's important to keep this in mind when you're thinking about different muscle activation patterns and stressors on the kinematic chain. And age-related differences really emerge in a runner's 40s, and it impacts their kinematics, their kinetics, as well as their injury risk profiles. And if we take a step back and we think about this presentation as a whole, running kinematics and the temporal spatial parameters these are key metrics measured by clinicians to identify and treat running injuries. This lecture is really foundational in nature because we consider it, you know, basic knowledge that all running specialists, PTs, need to have if you're going to be successfully working with runners. As Krista mentioned, running kinematics impact muscle activation, joint loads, and injury risk. These variables do vary by age, sex, maturation, and strike patterns. And we need to apply these principles as part of a comprehensive rehabilitation strategy. And it's important that we keep, you know, this in mind when we're working with runners, particularly when we're talking about how do we try to, you know, treat their injury. We don't want to overstate the importance of running form to their injury, but we also don't ignore it altogether. So it's important to keep it in context within your comprehensive strategy of treating your injured runners. So I'll stop there, and we'll open the floor, I think, for question and answer.
Thanks,
Jeff,
guys. That was excellent. So you guys kind of started from the basics and went into application there. We have a number of chats that you guys have been answering as you've been going here. We have some new questions as well. So do you guys want to just read out and repeat just to everyone in case they're not watching and tracking the chat and what we've kind of covered so far?
Yeah, and maybe I'll, Matt, if it's okay, there's a question I want to punt to Jeff here from
Great.
Hannah. Thanks for your question, Hannah. Um, I'll let Jeff answer this one. Jeff, Hannah's asking, is there a correlation in strike pattern and maturation of females versus males? As males and females mature, are there tendencies to change strike patterns, which could then alter kinematics?
It's a great question. So this is unpublished data, so do with it as you know you see fit. But when we've looked at that in our cohort, so we had 143 runners between the ages of 9 and 19. They were all healthy at the time of enrollment. They had to be healthy for 6 months. They had to participate in long distance running activities like track and cross country. We did include soccer athletes, just because youth running programs at the age of 9 and 10 aren't super common. So, so it's not pure runners, but we did not really see differences in strike pattern. In our cohort, there was no sex differences between males and females. We also did not see a maturational difference. We put together an abstract. We presented at CSM maybe 3 years ago or longer now. And then what we did is when we stratified by, okay, do you identify more as a runner, as a soccer athlete? Our runners were definitely more consistently rear foot striking. If you played soccer and you ran, or you just were a youth runner, a youth soccer athlete, like our prepubertal runs, they tended to be a little bit more midfoot. And so it's possible that when you participate in just running, you may be more prone to developing a pure rear foot strike pattern. But if you participate in soccer, it appears soccer might influence your strike pattern in running. So that's not published. It hasn't been peer reviewed. So, you know, but it's an abstract. We did present at CSM, and maybe one of these days we'll write. But I think most people have a lot of abstracts they're sitting on. But that's the best I can answer that question.
I'll just add briefly, same as what Jeff said, anecdotally, I don't see significant trends one way or the other in the populations I treat either, unless once in a while I've seen a coach gets in their head that they need to tell everybody to run with a 4-foot strike pattern, or this person told this team to match this strike pattern. And that's when I'll see some trends, but I've never been able to tie anything specifically to maturation. And then Nate has another question. Nate asked, what are some key outputs that you like to look for and track to see if the interventions are improving performance? And Nate, I think that's a great question too. We can dedicate an entire webinar topic to that question alone as well. And I don't know if you meant to throw this in there, Nate, but you know, we haven't even really touched on performance. We've scratched the surface on injury and not necessarily performance. So I'm not sure exactly what you were meaning by that specifically, but I would say in general, my answer to your question is that it's very injury dependent. It's very patient dependent in front of me. Are we performing a step rate modification? Are we performing a foot strike change? And in that case, whatever I'm trying to manipulate with that runner in front of me is what I'll use for my outcome measure that I'm tracking.
Yeah, I'll give a plug for work that's been done out of Wisconsin. So every runner who comes to see us at Cincinnati Children's receives the UWRI, and then we track it every 30 days. And the UWRI, University of Wisconsin Running Injury and Recovery Index, it's a valid and reliable tool. And it's really a running specific tool. And clinically, I've been using it for, gosh, as long as it's been out, probably even before it was validated. And it goes from 0 to 36, and 36 means you basically perceive yourself to be completely healthy without any limitations. I like to see a runner have a score 29 or higher as discharge criteria. And it's really interesting. There's some sub questions in there that get into some of the fear of making training changes. And so I use that to have a good conversation about, you know, their psychological health that they're experiencing with the running injury. And if fear is really holding them back, you know, we have sports psychologists we refer people to. So that's a PRO that I want to plug. But yeah, I totally echo Krista. You know, everyone has unique goals, and we try to just align their goals with the outcomes we're seeking. So I don't necessarily look at like, oh, did you achieve your kinematic goal? Yes or no. That's just, you know, it's really more like, you know, are you back to doing what you really want to do? And if your kinematics were part of that, I'm curious to see if they change, but it's not the key driver. I wouldn't hold someone in therapy forever and ever if their form didn't change, but they're back to running pain-free.
For those that are still sticking around here, maybe I'll take this as an opportunity to circle back to one of the questions that was asked above about how much, in general, to summarize the question was how much weight do you put in your running analysis? And you know, you've heard both Jeff and I say this a couple times now that these injuries, the runners that we're treating, it's the whole picture, it's multifactorial. And Jeff mentioned this in his answer. Oftentimes he does this and I do the same. I dedicate an entire session to a running analysis only. But that doesn't mean that I'm only looking at a running analysis. Oftentimes, like Jeff just said, there's a fraction of what I'm doing to helping that runner overcome their situation is addressing kinematics, but it very well could just be the training plan that their coach has them on at that moment, or the old shoes that they're, you know, there's so many things that go into it that it's never just one kinematic measure that we're measuring. But I do think it's important to mention that I do take an entire session to focus on that, but I educate the runner that this is not the only thing we're doing. It's just a piece of the puzzle.
It's great.
New question in here is how do you account for treadmill versus overground running differences when collecting kinematic data?
It's a great question. Thanks for the question, Manny. I'll say that most of the athletes I see in clinic are treadmill. So just out of convenience, it's easier to capture data and confine them to a limited space on a treadmill and perform some manipulations and modulations on the treadmill for a variety of reasons. But there are known differences between treadmill and overground running. Usually a slightly increased step rate and a decreased step length occurs on the treadmill. But again, I just keep that, or I'm aware of that and use that when I'm educating my patients too. And actually, I think probably the biggest thing between treadmill and overground running is that a treadmill can allow that patient to remain at a constant speed, which is harder to obtain when you're talking about overground running. And then if you're trying to implement a gait modification and your patient is running overground, more often than not, they're just going to change their speed and not truly change what you're trying to with their gait. So yes, there's differences, and you just have to be aware of pluses and minuses of both.
Yeah, regarding the cadence piece, what I tend to do is, like, if we measure their treadmill cadence is like, say, 168 at a certain speed, I'll ask them if they have a Garmin, type watch. Say, hey, can you put out your app? Can you look at your app and find runs that you ran at the similar speed in the last month or so? And then I will ask them to show me their cadence to see, did what they did today on the treadmill, was it representative of what they do over ground, or was it significantly different? Because if I'm going to do a cadence manipulation and they're going to say, I'm going to do this primarily over ground, I don't want to give them a value that's artificially high because their cadence is higher in the treadmill than over ground. So I will use that sort of like as a validity check. And interestingly, some people are almost like spot on, and other people there's a very big difference. So that's one thing that I will do, that I make a note to do. Now, of course, not everyone has a Garmin type watch, nor do they have to. But if they have it, it's nice information. I like data, so when people give me more data, I'm like, oh, okay, thank you. I'm happy to take more time to look at this.
Yeah, I think over 90% of runners now have some type of wearable. So that's a great way to go about it, to validate your treadmill versus what they're doing on the roads. Other questions from the participants here?
Looks like Colin asked a question. Do we see female step width increase in correspondence to hip development during puberty? Or is this part of the reason for the hip adduction moment increases? I can say in my study, we did not. This is data that we haven't looked at yet, which is our temporal spatial data. Probably should. Seems like a pretty good thing to look at. We haven't looked at it yet. I'll leave all discussions on hip moments to Krista. She's an engineer.
Yeah, and my response too was just that what I know of the literature, what we've looked at so far is we certainly see a difference in step width or base of gait between men and women, but not necessarily over one sex through maturation, through puberty. Honestly, because I don't know that we would be able to apply that information clinically. I don't know that our tools are truly sensitive enough to give us clinically relevant information of base of gait through maturation. I don't see my patients frequently enough to capture that across puberty. But it's certainly an interesting idea and something that could be looked at. We know there are pelvic differences. We know there are hip adduction differences. And like you mentioned, Colin, they're probably associated. But I don't necessarily know that what that picture looks like across puberty.
Great. And just to summarize some of this other stuff, it looks like you guys are both in strong agreement that this is very multimodal injuries and so forth, and this is a small component of it's a component nonetheless, though. And as Jeff mentioned, to be really true to what you're doing when you're working with runners, you got to be looking at this still. So, um, other questions from the crowd right now? If not, thank you everyone for being here today. Just a reminder to continue to check out the AASPT website and calendar for more journal clubs, podcasts, and webinars. These two are back in 1 month for another webinar. They alluded to this quite a bit earlier, so they're going to be doing more about gait analysis at that point and kind of building off of where they started here today. So be sure to register for that one. And with that said, thank you, Krista and Jeff, for leading this today. Appreciate you.